It's an absolute delight and pleasure to be here speaking to you online. So, therefore, good morning, good afternoon, and good evening for all the colleagues who are in various parts of the world and listening in. Uh, I'm going to essentially talk about two projects. One is the LDI Reach Initiative, and the second one is Ampli PPHI project. Both of these projects are from, and of FIGO and being implemented here in the country by FOGSI, which is the lead organization. But before I begin, I must really thank Professor Rishikesh Pai for inviting me and for this special occasion, and under whose leadership this entire program is being conducted, which is called the International Summit for Women's Health and Rights. And it's interesting because Rishikesh has been kind of the key person who has been leading similar initiatives for last several years, and this is one of them on which I'm going to talk about. So LDI initiative is a FIGO project funded by the Gates Foundation. It's being held in countries like India, Bangladesh, Ethiopia, Kenya, Nigeria, and Pakistan. It's a 4-year project where Rishikesh is the project head. Myself and Dr. Madhuri Patel are the core national team members. And we have 4 key centers, 2 in Uttar Pradesh and 2 in Bihar, who are conducting this program. And we do have 50 leaders from within FOGSI who are kind of taking the entire project forward in every sphere of their interaction with the individuals in various societies. The aim essentially is to strengthen the leadership skills of the society and its members, adoption of maternal and newborn interventions, and bringing in some kind of gender transformative approach to champion women's in leadership. But more importantly, I also like to stress upon the addressing of the barriers aspect to it, because when you're implementing programs and initiatives, there are several barriers that facilities face, and identifying these barriers and also providing solutions for these barriers is how we can make a program successful, not just in the pilot phase, but also when you try to scale it up. So we are anticipating all those challenges and providing solutions for it. The clinical focus for this particular program was on 2 areas. One was the providing hematinic agents for anemia, especially with a focus on IV iron. The second one was related to the emotive implementation, that particular trial for PPH. We have made tremendous amount of progress since the project was launched in 2023. We have created about 50 leaders across the country. We have completed the barriers assessment, phase 1, phase 2, phase 3, phase 4, and phase 5, and we have identified several of them and have overcome most of them. We have prepared a evidence-based curriculum. Now, this was done specifically with various, technical teams getting together and making this curriculum so that everything that we deliver is uniform, and everyone who talks about this project and the technical aspects related to anemia and PPH speak the same language, because that was very critical. We do have data collecting tools and the reporting formats. The reporting formats capture a lot of data related to anemia and the PPH and how the 4 centers are performing. And this data is kind of shared every month with FIGO, and a complete analysis is done of the same to see where we are and how we are progressing. I'll talk about the data in a bit in the next couple of slides. We did complete the leadership empowerment series training program, and there was a gender training and orientation was also completed related to this. Advocacy for this project and the work that we have been doing has been going on full swing. Almost about 5 national international conferences is where we have participated and showcased what we have done for the project and how we have progressed. So this includes the Femtech 4 and 5, the All India Congress of OBGYN, which attracts anywhere between 8 to 15,000 people, was completed in 2024 and 2025. And we did have the South to South conclave in 2025. We have built a lot of salience related to the initiative on emotive trial and PPH itself. Almost about 92 programs on these two as well as anemia have been conducted, which includes training programs for various OBGYNs and the nursing staffs and participation in conferences. Almost about 8,000 plus people have been reached through this program. We have established a partnership with the State Health Society and UNICEF Bihar. And in this particular program, Dr. Alka Pandey, who is one of the center leads, has taken personal initiative in reaching out to various district hospitals and the headquarters of those districts and trained the various staffs over there. We do have a ready reckoner which has been created, which includes a poster and a flip chart. This poster is available to everyone within FOGSI and worldwide through the FOGSI website called fogsi.org, and there's an icon on the home page itself. It talks about LDI reach. Once you click on it, you will have access to the poster and the presentation, PowerPoint presentation, and you can download this poster, which talks about the escalation chart, and it also talks about the protocols which are necessary to be put in place related to the PPH management itself. Talking about data, because at the end of it, where are we? I mean, basically, where did we start and where are we as far as the program is concerned and how the four centers are faring? In all, Dr. Alka Pandey, Dr. Vinita Singh, Dr. Uma Jaiswal, and Dr. Neera Agrawal are the four center leads who have taken the project forward in their centers and implementing everything related to the project as is defined within the tenets of what we need to do. Almost about 5,500 deliveries have been attended. We have identified about 344 cases of PPH anemia, about 1,200 deaths due to PPH were about 2, neonatal deaths with due to PPH were about 5, and we did have near miss cases of about 16. It's interesting to point out the chart over here. The first part of the chart shows when we began the project, and if you see in terms of the implementation of the project itself, most of these four facilities, you see, they were at 0%, 0%, 25%, and 0%. So they were at the bottom of the entire chart in terms of its overall implementation. And as you see, quarter by quarter, the implementation has improved dramatically to the last quarter that we saw, that almost 3 centers out of the 4 are at 100% in terms of implementation of every step that is required to be fulfilled in order to make sure the PPH management for the women who are coming for treatment in their respective facilities are indeed taken care of. One facility is not at 100%, and this is a very large facility. It's a public facility with almost 350 to 500 deliveries per month. So we are working very closely with this particular facility to see that they are in the highs of 80s to begin with and eventually come to about 100%. So that's where we are with these 4 facilities. And this is a very interesting slide that we talked about and shared with all of you all. With that, I would like to move on to the second project, which is related to it's called the Ampli PPHI. Accelerating measurable progress and leveraging investment for PPH impact. Now here the team lead is Dr. Professor Nandita Palshetkar and myself, who are implementing this project along with several team members in India who are essentially FOGSI members who are taking the torch and the light forward in various societies across the country. And now, what is this project and why this project has come about? This kind of chart defines the entire need for such a project, especially in a developing country like India and several other South Asian countries as well. When we look at the data itself, we talk about 810, women die during pregnancy and childbirth related causes every day, and of which almost about 87% are almost in sub-Saharan Africa and South Asia. Now, if usual progress continues the way it is at this point in time, in the chart on the right hand side, you'll see the top line is if it continues as usual, we are not going to meet this SDG 2030 goal. But however, if we add another 5.4 percentage points to the entire initiative, we see the middle line, which definitely has a fall there, but it's definitely not going to reach the SDG 30. So if all countries have to meet the SDG goal of maternal mortality ratio of less than or equal to 70, the yellow line is where we need to be, and therefore the steps need to be taken now and continuously to make sure it actually happens for the women of the world and women of our country in India. When we look at the PPH in the region itself, there is a definite linkage between anemia and PPH itself. The chart on the left talks about the anemia cases in India, Pakistan, Nepal, Sri Lanka, and Bangladesh. And on the chart on the right talks about the percentage contribution to MMR due to PPH. MMR essentially is maternal mortality ratio. So you see, all of them are high numbers in terms of numbers itself and in terms of percentage itself. So and there is on an average, PPH contributes about 36% of all maternal deaths in the region. So which is pretty high, pretty scary, and pretty something which is a cause of concern, and therefore urgent steps need to be taken and continue to be taken to make sure we alleviate this particular issue. When we talk of postpartum hemorrhage, we have established that it's a leading cause worldwide, yes. And we do have a challenge in terms of, where we are and where we need to go. And when we look at, India itself, we do have tremendous amount of progress over here. Government of India, Ministry of Health and Family Welfare has done tremendous amount of work across the country to make sure it actually happens, and we have seen tremendous amount of improvement, thanks to the efforts put in by Government of India and the various facilities across the country. But a lot still needs to be done, because we're talking about 25 million births a year. MMR 93 per 100,000 live births, which actually has gone down as per the latest date, SRS data, which is like 93 per 100,000 live births, and translating into about 25,000 maternal deaths per year. So which is significant. And when you ask you and me what's a maternal death you want in your family, the answer would be zero. So therefore, why should these 25,000 maternal deaths also take place in our country? And Ampli PPHI is an initiative which is contributing towards making sure we are able to, bring about a change and add to the reduction of MMR in our country. So Ampli PPHI is a project funded by UnitAid. Project partners include JPIGO, FIGO, FOGSI, which is a lead organization implementing it in India, and PATH. Project countries include India, the DRC, Guinea, Kenya, Nigeria, and Zambia. We have exchange learning states of Uttar Pradesh, Bihar, Assam, Chhattisgarh, and Odisha. And we have, as part of this entire consortium, learning exchange countries of Nepal, Sri Lanka, and Bangladesh, where we are interacting with them and making sure, we are, giving them all the support that they need as and when required, including the technical as well as, other findings that we are having while implementing the program here in India. The goal is to catalyze early adoption and scale up of new and recently recommended drugs to prevent or treat PPH in high burden states and countries as part of an integrated package for PPH. Here, the focus is on 3 drugs. The first drug is heat stable carbetocin. So while we do know, and oxytocin is utilized everywhere, but it does come with a set of its own challenges in terms of its storage. Therefore, a beautiful option, a fantastic option is in HSC, the heat stable carbetocin, which is what we are trying to promote. Tranexamic acid is another one, and misoprostol, where we are looking at seeing how we can, communitize it and, make it available through, the community healthcare workers for women for self-administration. What we have done so far is actually quite a lot. We do have tremendous amount of advocacy efforts which we carried out at the AICOG, the All India Congress of OBGYN, in 2022 and through to 2025. Everywhere we've done it. We hosted and conducted an exchange country hub meeting, which included Nepal, Sri Lanka, and Bangladesh, and of course, the entire leadership team from India. We have participated in about 40 meetings, training, conferences at the state and society level as well, and reached almost about 3,000 plus fellow OBGYNs and paramedics whose capacities have been built related to these three drugs, and particularly a focus on PPH itself. We have participated in the FOGSI SAFOG conference and the FOGSI FIGO GUCOG conference as well. Here are a few glimpses of those very events that we have participated in. The 14th SAFOG conference where we had, so we have the entire leadership team there talking about it, and also giving a kind of picture perfect scenario for us. There we have on the left hand side our leader Nandita, who's talking at the AICOG in 2024 advocating for these three drugs. On the right hand corner we have our participation in AICOG 2025 led by none other than Jopaigo. Dr. Parag Bhambre is there, and the entire team, including Unit Aid and Gates Foundation, is present on the dais, where we addressed a panel and addressed various questions from the audience as well as the panel lead. We continue with our efforts. We have the learning resource package, which was developed and released, which is a standardized LRP. We do have 2 job aids on HSC and TXA, which were released. District level workshops were conducted, co-investigator workshops were conducted, and importantly, the data collectors play a critical role in this entire program, so their training was also conducted. We did have a stakeholders a consultation on improving the access to drug, because that is another thing. You may have the drug but you may not have access to it. So what sorry so what are the barriers for it, and how we are going to improve and change that, overcome those barriers, are some things that we talked about. So with that, thank you very much for your patient hearing, and I will be happy to take on any questions that you may have related to both these projects. Thank you very much.
That was really very insightful. Yeah, Hema, your view.
Yeah, thank you so much, Ajay. I just wanted to pose one question. Since you're leading the initiative in multiple countries, which you mentioned, what is the major difference that you find in execution of the project? What are the barriers? What are the challenges? Because we presume that South Asian countries all are almost similar, in there. Are we ahead of the curve when compared to others, or how is it going in a healthy comparative way in various countries? Any comments?
In fact, thank you very much, Hema, for this question. And it's an interesting one, because what we have seen is you have across the countries, in terms of, when you look at a common line drawing across the countries, you have fantastic set of people, extremely dedicated and committed to what they need to do and what they are planning to do and how they are going about doing it. They are well planned in terms of the overall implementation, and they are basically at it. And so is India. Okay. Having said that, one of the key things which is coming out as a barrier, so would I say, is that when approval of these drugs at the ministry level or at the country level and making them available. I think that's where the gap is, and that's where a couple of agencies are working to make sure, including the various societies who are in those countries, are working toward making sure they are able to navigate that space, advocate for the availability of those drugs, and making it available. So the science is there, the evidence is there across the country. It's just that little bit bridge, and few of the countries have already crossed it. So out of the 3 drugs, 2 are available, or 1 is available. And I must also say about few other countries that what they have been able to do, particularly for the emotive trial and the assessment of the quantitative loss of blood loss as against the visual estimation, which was the common prevalent thing across various deliveries, is that while DRAPE has been recommended as per emotive trial with the clear measurement, clear markings and everything, few of the countries have done fantastic innovations. Some of the countries have used a plastic bag, clear plastic bag, with physically marking everything down. Somebody religiously sitting down in that OT and marking down those plastic bags for multiple uses. And our own country, apart from using the V-drape, we have innovative with a tray, which has got a marking of 500 ml and excess blood going to the second compartment, which makes it to the 1,000. So that's another second innovation. The third one is people using the Macintosh drape itself and kind of funneling it into a bucket, those white buckets with a marking over there, which can be reused after wash, and you're able to clearly judge what is the quantitative and objective assessment of blood. So yes, we are in a very good space to answer that question, Emma.
Excellent.
And most of the countries are leveling up, and we are seeing a change, and we should continue seeing this change as we go forward.
Excellent. I think these innovations in itself could be shared between the countries. That's the first point. And secondly, it's all about leadership and influencing the policy and also the supply chain and the availability, as you've said. Nandita may have got some questions from the audience on her mobile, but meanwhile, when she looks at that, I just have one quick question about what has been the influencing factor for availability of heat-stable carbetocin in the public sector. Will this initiative be able to influence our government to make that available at a reasonable cost, affordable cost in the public sector, or because there are many states in the country who need the heat stability? So it is one of the very crucial steps for the potency of whatever we are giving to contain the ppH. So where are we regarding that, especially in India?
Okay, yet another question, and a very thoughtful one at that, Hema. And now, the first aspect is that we are in a very good space. Why? Because the HSC has been approved and is available across the country, and which means that the private sector is already using it.
Right.
Okay. And government sector doctors are also using it. However, it is not available within the system. So one would prescribe it if need be and make it available. Okay. Now, advocacy work on the front related to making it available through either the essential medicine list or having a GR across, various at the national level or at the state level, that process is going on.
And the dual pricing, Ajey, the dual pricing.
And the pricing. And the pricing is the biggest factor in all of this, where it is not. The advocacy work is going on not just in terms of why HSC is better or than oxytocin and thereof, but the second aspect is also that to back it all up with the India specific data, building that. So internationally data is there, but how it works. One needs to have that data available in the country for the country to be able to advocate that much more powerfully with the government. And thirdly, related to the cost part, the average daily lives saved for utilization of HSC vis-a-vis oxytocin, I think that's where one needs to look at the cost effectiveness of this entire aspect and not look at a per unit cost, but look at the cost in terms of the overall impact in terms of life saved. So that is the angle, or that is the platform that we are kind of building on, and continuously engaging with the government. So we are a bit far off with the government itself in terms of them making it, approving it, and making it available across government facilities. But I do know states like Maharashtra, Tamil Nadu, and Karnataka are already at it in terms of kind of bringing it out there, and work is already happening. So we are hopeful that it will all actually pan out and come out very nice. Thank you, Hema.
Yeah, great. Nandita?
I think that was really good. In fact, Hema, the other learning that has come out of it is, the women are being given misoprostol, who are the ones who have planned on a delivery at home because they are far away from, the hospital. Now, out of those women also, 50% of them who were distributed misoprostol did, institutional delivery. So I think we are looking at even the collateral learnings from this project, and I think that's wonderful. The PPH Ampli has given us a lot of learning, and we are publishing all this data. So as Ajey said, the data is homegrown, and that is why it's so valuable. So thank you, Ajey. Thank you, Hema. I think it was a wonderful.
Thanks, Ajey. And for our Nandita, for our Manyata leader, Dr. Rishikesh Pai, we must tell him that because the private sector is using carbetocin already, there could be a lot of data from our private Manyata centers to gather and in a defined protocol, and that could be then brought to the table for the public sector to make this available, and we can always negotiate the costs in the shortest possible time. So Rishikesh, that is on our agenda.
There's a lot of interaction. We have the Manyata program going on. We have the two programs which Ajay's foundation, Avni, is tackling for us, the Ampli PPH, the Elder Reach program. Now we have the newer Gates Foundation supported FOGSI program, Aduna. Then we have the Sampurna, which is the SIP Foundation. So all are connected, and that's what it is all about. We have to ultimately connect all the dots and see to it that we bring the MMR down, which is already down. I'm sure that as India becomes more developed, and that's the same story with all the countries in the world, the LMIC, the Western countries have already reached that goal, and the other countries are also catching up quite well. And I think our organization, especially the FIGO, I feel it's well positioned with this all 139 countries. If we collectively work, I always feel that implementation is what is necessary now. We have the ideas, we have the protocols, we have the goals. Now let's get down to actually implementing it, which we have done in India. We have achieved a lot, and maybe that learning we can give to our other brothers and sisters across the continents, all the South, as well as many of the Eastern European countries and all. They also have similar problems which we face, because it's all dependent on economic development also. We are all evolving nations, and as we evolve, we are going to achieve our goals of a decrease in maternal mortality. So I think thanks for, because some of the giants are there in this, at the twilight of our session today, we have Dr. Hema Divakar, Mr. Ajey Bhardwaj, who is also a giant in this field. Nandita is there, and we have a junior in the form of Tanya, also one of our fellows, who is learning from us in imbibing. And we have 3,700 people are registered, and 1,900, I don't know how many are there online at present. Our Dr. Shantanu, also one of the young Turks, is there in the audience. And so we are getting there, and we are looking forward to meeting all of you in Cape Town, where we will have fellowship, interaction, learning, learning from each other, and interacting, getting new ideas, So it's a exciting life ahead for all of us.
And Rishikesh, this session is actually running ahead of time. And it speaks volumes of us being ahead of time in a sense. And with your philosophy of integration, which you have always believed in, and inclusiveness, which also is your very strong point. And that's how we've got us all together in this mega webinar. And we really, really appreciate and hope that we will be able to do a lot more to the world at large. Thank you.
Yeah. In
Thank you,
fact,
Ajey.
Both of you.
yeah.